By now, everything is clear. Thank you, BLCs. You did a great job, collected a big number of questions, helped me out a lot for, articulating the things. And I spent good time yesterday. Almost, I think when I finished, it was about Fajr time. And then I had a choice to sleep or to. Anyway, I did what was necessary. So, without wasting further, first of all, before starting, this is a review session. This is not a teaching session again. I have two model questions to share with you first. And then, guys, during the course of MSK, we tried to talk about real important concepts. There were so many things which, in my opinion and your opinion, may be very interesting. Yes, medicine is all about interest. And I can see you have the interest. You develop an interest. And that's a good sign. I can see, inshallah, we'll have a big number of doctors who are highly motivated are coming up. So with this note, I like to start. When I was going through your questions, there were some questions which were dragging me into the depth of the subject. And on purpose, I avoided at certain areas there was so much depth. I love to talk on those issues, but not today. Because I like you to have a successful journey from this blog. And I don't want to engage you in undue, unnecessary details at the time span. I appreciate you want to pursue your career as an orthopedic surgeon. Welcome to the club. But there's a timeline. The timeline, which is set for Saturday, that is testing a bunch of smart students who can handle the small basic concepts connected to the appendicular MSK system. Someone was asking me, I like that. We have only covered about the muscle, joints, bone, and everything of extremities. We didn't learn about other muscles. Because if you look at the books of the MSK, they cover all the muscles. But remember, I told that person, I wrote that person, look, we are following a hybrid version. You adopt things. There is nothing 100%. You adopt things. So we adopted that we will be, because this is your first regular learning phase. So we adopted what? That you should be given in piecemeal, in chunks, not as a whole. So that's why with each upcoming blog, you'll find the MSK content of that pertinent blog with that contents, with those contents. So that's why we only separated out the extremities, the upper limb and lower limb for this MSK. Ideally speaking, MSK should cover all the muscles and joints of the body, but we adopt according to our needs and according to our own philosophies. There is a big list. You may agree, you may not agree, that's not our discussion. So without any further delay, and one single word is that the rule is what is expected from you and what is for learning. People try to learn everything from everywhere, but the better policy is you should learn something from everywhere. Learn something. Not everything from something. So don't choose between upper limb and lower limb. Upper limb, lower limb, everything, something of upper limb, something of lower limb. But whole upper limb, whole lower limb. It's not like, oh, I'm good with the foot, rest, I don't know. I'm good with the upper limb, lower limb, I'm suffering. No, that will not help you. And we are targeting, we are always following, I'm not saying 100%, but we always try to go over and we try to stay within our objectives. We don't like to give people surprises. We show you We assess you on what you have seen, what you have learned. There's a simple rule in assessment. If you are teaching something and you are not assessing it, then question is why you are teaching it. So, first of all, I have something worth showing, and this is a question which I received. I think I can minimize this window here. Maybe it's obstructing your view. Yeah. Somebody was asking me, it's a very, I really enjoyed this question. What are the primary flexors, extensors, medial and lateral rotators of the hip, knee, and the ankle joint? I like this question. A very, very elaborative question. And before answering this, there is another question. That question is, what are the primary flexors, extensors, medial and lateral rotators of the shoulder, elbow, and wrist joint? Now my question to the person who wrote these, if I try to answer your question, probably I need another 6 weeks because you are asking everything what we have learned. So, my dear fellow, go back. Everything has been explained, and this single question is covering whole of my upper limb and whole of my lower limb. If I add on the nerves and arteries to bit, then we are done. It's the 7th week exercise, which you have just inserted as 4-liner question. So this is not a question. This is like start teaching again. And I think most of the people, what do you say? Anybody like to answer this question from the crowd? From the class, I like somebody to answer this question. Ask on the Zoom. Zoom is connected to me. I can see there are at least 181 people. They are connected. But how much they are connected, that's a different story. So guys, I'm waiting for your answer. Let me open the chat box. So what answer is for this question? Answer for what? Answer for what I'm trying to show you. The question which has been asked to me. So please, when you are posting a question, make sure your question should be meaningful and it should serve the purpose. Okay, it's okay, we are learning. I take that part. So, now today I'll be reviewing, and these are my 6 slides, 6 sections. I'm not saying 8 because actually they are 6. 2 are extras. So let's take one by one. So I have divided your questions into different categories. Journal questions and then specific questions. So now in the journal category, the first question was asked in the last slide of anterior medial thigh. What does it mean that the long saphenous vein may also be accessed for inserting intravenous lines when other peripheral veins are collapsed or thrombosed? So, basically, this is a concept, and this concept is used for when we talk about the clinical usage of my great and small saphenous veins. We all know these veins are superficial veins. And I'm sure most of you have noticed or experienced in any hospital setup when you go for any reason. Obviously, we are not going to hospital for just a party. We are going for some problem, with some problem. Either we are suffering, or we are accompanied with someone who's suffering. So under normal condition, when a nurse wants to take out blood, let's say your doctor order a sample of blood. The target is venous blood. We don't need arterial blood. Arterial blood is needed on very specific circumstances. And what are those circumstances? When somebody is really sick and he or she is in an ICU or HDU, and we need to assess the blood gases estimation. That's a very specific, different type of test and a very specific way it is being done. So that is only test where we use normally the arterial blood, otherwise we use the venous blood. Now in the normal situation, everything is fine. You can access in most of the situations. I'm using the word most of the situations because we have extremes. If you are dealing with an infant, a child, it's difficult to access his or her veins. It's not like that the veins have not developed, veins are there. But you know the children, they're scared, so they try to run away, they don't stay quiet, they start jumping and doing everything to stop you. So there it becomes little tricky, so please don't try it. Leave it for, no matter how good you are in taking blood samples, but with the early age of people, try not to get in that, otherwise you'll end up with some shameful retrieval, and the poor kid might be having so many punctures in his hand and other places, so don't do it. Because for this purpose, there are very specific trained personnels. They have their only job is to do that work. So they are doing it. But now, and there are certain obese people where the superficial veins are super embedded in fat. So now it's become difficult to dig it out. That what should we do and what is happening. So now, but there are, any person who's normal, we all are normal, under certain condition, when we are in a state of shock. I'm not teaching shock at the time, but shock is a condition, clinical condition. And one of the manifestation of shock, somebody developed diarrhea, severe diarrhea, not one motion, like, in last 1 hour, 7, 8, 10 motions, and then almost dehydrated, or someone is excessively vomiting, or someone has lost significant amount of blood. Now the person is in a state of collapsing. When the person is collapsing, the veins, the superficial veins, because all are connected to volume. So volume is being depleted. So the superficial veins are usually non-accessible. You cannot find, veins were there, but I cannot see any more vein here. So, and let me give you another example which is connected to your MSK. You are in an ER and you received a youngster, maybe somebody 18-year-old. He was showing his actions on his bike, and probably he was trying to do drifting or some other activity, what bikers do. And his bike got slipped, and this person has fractured his shaft of the femur. If such person visit to your ER, I remember we were advised, if you receive any person with a shaft fracture, femoral fracture, specifically, proximal, middle, distal, it's okay, any part of the femur. You should not talk to the patient first, put 2 IV cannulas. You are sure this is what you're dealing at, and just connect 2 IV cannulas and start some fluid, because these people, what they have damaged, a force which was that strong, that has damaged one of the strongest bone of the body. So what about the blood vessels, the arteries, those who are going so close to this? So fair enough chance. This person also have damaged, ruptured profunda femoris, femoral artery, anything, popliteal artery. And the bleeding from these arteries is phenomenal. And in my thigh, I have enough space, maybe 2 to 3 pints of blood. Pint is a unit which is used for measuring the blood, and that is around, I don't remember exactly what is the value. It's around 500 mil for each pint, something like that. So, pint is used at different places. I'm not getting in that discussion. So, around 3 bottles of blood, if they drain in the thigh, you cannot see it because this bleeding is inside your thigh. Only it is little bit swollen. And out of my 7 liter, if I lost in few minutes this much amount of blood, I will be collapsed. And when I'll be collapsed, I'll be on the floor. Why I'm on the floor? Falling on the floor is a blessing or is a bad thing? Blessing. Thank you. Why blessing? Because my brain needs blood. And if I'm standing, less amount of blood is going to my brain. But when there is a shortage of blood, I will fall down. When I will fall down, so as an act of gravity, the blood will be forced or blood will be going to my brain. And in good hospital setups, in good ERs, they have special type of jackets. When they receive these patients of polytrauma, they wore those jackets on them and they inflate. So whole body is under that pressure. So what is the advantage of those jackets? You are shifting the blood from the extremities towards the central system, so that we all know there is blood loss, but we have to utilize whatsoever is available. And then when we give these people blood, these blood bags are kept in very special type of jackets. They are super squeezy on those bags. So blood is being squeezed through the veins into the human body. Guys, these are not the normal situations. These are very extreme life-saving maneuvers. So maybe you have not seen them. They are connected with so many ifs and buts. To cut short the story, your vein is not accessible. I cannot see where median cubital has gone. I cannot see where is dorsal venous arch which is on my dorsal surface of my hand. I cannot see any one of them. So now what to do? So thank you very much. I will plan a small surgery. I know where is the location, where is the best location near to a bony landmark, medially, my malleolus. I'll make an incision little above. I know this is the place from where my great saphenous vein has started its journey. I can just cut the skin, it is a superficial vein. I need not to go deep into the deep fascia. It will be sitting just there. I have to identify. I can see a tube going up. Guys, you will not find blue color. It's a whitish kind of thing which is there, and as the patient is collapsed, so it will be collapsed. So we cannulate, we put a tube in, we fix it, and then we connect blood, any other normal saline or ringer, whatsoever solution, whatsoever thing you have to. So this is called venesection or cut down. So great saphenous vein is one of the utility. Or there is someone who is in an ICU, and every day you have to give him nutrition through the injections, nutrition, antibiotics, and other medication. So, and now every time, and his veins are not easily accessible. So we connect this tube there. And guys, this is not the only place. We have other places, but this is the safest place, far, far away from my normal thing. The best practice in current days is now we adopt CVP lines. And these CVP lines, I think I'll talk about those CVP lines in CVP block, not today. So those CVP lines are targeted through the subclavians, and then we can access even into the right atrium of the heart and all that. We can measure pressures and other things, and that's something which is to be used in real resuscitation. Anyway, the subject goes long. I don't want to get into this much detail, but simply for you, great saphenous vein is one of the commonest site used for venesection. Second, used for graft when cardiac bypass surgery. This question will be coming up as if I'm talking about it, so let me zip it here. Somebody was asking me that how you replace a vein with an artery. Look, artery is a tube, vein is a tube. And under special circumstances, from where, which artery of my body, if I cut it, how I cover that missing part. So the part from where that artery was supplying, that part will no more be functioning, that will go gangrene. So we cannot chop away an artery. But this great saphenous vein, we can spare it. Why we can spare it? Because we have so many perforators, and they will take care of the job of great saphenous. So we use it. Now the second question which was asked somewhere, I saw in the chat or in the asked questions, it has valves. So how you, and somebody was asking me, I think I mentioned even in my slide, they take care of the valves. So what we do for the cardiac bypass surgeries, when we take out these veins, great saphenous vein, then we have a term use harvesting, and then we basically we revert it, we put it upside down. So now the valves are acting in an opposite direction. So now it will not be causing problem with the flow of the blood. Are we good? So these are the things, and I think I have answered what was the intention of this question. This is an important concept, and you should be, look, this is not even for your MSK. It should be, this concept should be parked in your lifelong memory. Anyone listening to me, sitting here, like to pursue his career as a physician, will be encountering these things maybe today, maybe tomorrow. So you need to be stay connected with this concept. Now, how does the profunda femoris ends? Profunda femoris ends by giving its terminal perforating branches. Somebody was asking me when we use the term branches and when we use the term terminal. So branches term is being used when something is branched off and the main artery, main structure is continuing its job. And once it finished, because profunda femoris is given a task that you have to supply the deep structures in the front, in the middle side, and on the back of the thigh. So they are working. Guys, there is no boundary. Oh, this is the area for this and no other artery. So obturator which is there, it also helped him out. So there are so many connections. That's why, if I'm not wrong, Dr. Sadia has explained a lot about the trochanteric and cruciate and the vertical anastomosis. So basically these anastomoses are not only for useful when we have some problem with the main arteries, but they are also helping, they are also connecting different resources. So if somebody has a problem with one artery, the others will take over. And second, they are supplying, they don't have specific boundaries. Nerves have specific boundaries that this nerve is made for this muscle. But arteries, they go and they just... Somebody also asked me an interesting question that was about the arteries. Can we grow arteries? Under normal condition, we don't grow arteries. But when somebody is doing too much muscular activity, you are spending good time in the gym, workouts, so your blood demand has been increased. So the arteries also become more dilated, more caliber increases. But it's not like, and the question was, the concept was, will we have new growth of the arteries? Yes, we have, but under not under normal condition. When it happens, when someone is having a cancer. So a new structure is emerging up. A new migration has started. So this newly growing structure, which is not the part of a normal human body, needs its nutrition. So then we use the term neovascularization. So for that cancer part of the body, the new vessel grew up. That's a different mechanism. Don't put your efforts for that. I just mentioned for the sake of clarity. Nobody will be asking about new vascularization in this MSK exam. So relax. So I hope I have answered how does the profunda femoris ends. It ends by giving its terminal perforating branches, and we name them first, second, third, fourth, and fifth is also been there. Maybe books are writing and not writing. It connects and it goes down, but it ends here. The journey ends for profunda femoris. Its other name was deep artery of the femoral artery, so its job is to supply the deeper structure. Guys, always learn the main terms. Don't get yourself compartmentalized. Go with the big, broad concepts. Okay, so what is the difference between common and proper plantar digital arteries? Guys, if you remember, when I was talking in the hand, thank you, in the hand and foot, I told you we make an arch. And from there, when this arch giving branches, and according to the structure they are passing close by, their names has been changed and changed and changed. You're not supposed to go in those details. Simply learn it. These arches give digital branches, and these digital branches are designed to supply your digits or your toes in the foot. So just stay connected with that and don't put your time in learning common, proper, and then ultimately it ends up at digital. If you want to pursue your career as a hand surgeon, it's a very interesting field, then probably you need to know. But we are not like, I'm not encouraging to get into this detail. Simply remember, from my arches I get the digital arteries. And I should know where are they supplying the digital branches. Maybe I am asking too much and I don't know what is the exact benefit of this. Okay, so how can a vein replace an artery, although it is different in structure? Yes, I think I have answered you. Structure, we are not bothered with the structure. Tell me, someone has a severe injury, crushed. Some major arteries are crushed. Let me put a worst type of example. Somebody has damaged his leg. Both anterior and posterior tibial are gone. Or maybe anterior tibial is gone. Now, how I replace that anterior tibial? From where I get another tube? No store sells it. When I'm hunting for a graft, fine, if I'm located in a big city like Riyadh, I might get it. But if I'm placed in Shigra, in Majma, and it's a stormy night, and I don't have enough time, may I send somebody, let's say in the middle of the night, if I send somebody from Majma, he will come to Riyadh, it's a night time, from where this person will buy a graft for an artery, because they are not being sold on normal pharmacies, they are not being sold on Sedlia. They are only in hospital supplies, and which hospital you will contact and they will give it to you. And how much you will keep with you, oh, if we need it, you don't know what you need. So there's a shelf life and these are expensive gadgets. So in those situations, ideally, we should replace it by a graft once it's a planned surgery. But if it's an emergency surgery, now I don't have, maybe my unit policy is like let's say I'm working in a big hospital. I'm working in John Hopkins. So there we have a vascular team, vascular unit, and they might have all the facilities. But maybe I'm working for a hospital which is located in Batha, and very minimal basic requirements are only available there. So how and from where I can get things and who will give me the things at that time? So in those situations, we need a tube. Easily accessible tube is my great saphenous. We can take it and we can replace it because we are replacing a tube. I agree with you, structurally a vein cannot be an artery, but this great saphenous vein is enough to do the job. The purpose is what? Why I need it? I need my anterior compartment of the leg to survive. I might get a fancy platinum or gold made or Teflon made graft, but if I don't get it in time, there is no benefit. I hope I'm clear. Yes. We also use, it depends on different people, they have different policies. So they may use any of the things. So great saphenous vein, small saphenous vein, basically it all goes on your preference. I have two options available. May I ask you, when you like to use your Mercedes car, and when you like to use your Beamer, it's your choice. Today I want to use my purple color car. Fine, I'll go in that. Today I like to use my pink color car. I'll use that. It's your choice. And then we work under different setups. If I'm trained in a unit where the policy was we were used to of using this, so I'll go for that thing first. But both of them can be used, no problem. There are other options, but I'm not going in those details. Otherwise, it will not be a level 1 MSK class. It will turn out to be something, an orthopedic discussion forum. Now, out of the general category, the question says, is introsseous membrane is considered a ligament? Yeah, you can say it is a ligament. It's a very strong divider, which connects, it's a fibrous sheet, which connects the intraosseous borders of my radius and ulna and tibia and fibula. So I have an intraosseous membrane in upper limb, I have an intraosseous membrane in lower limb, and these membranes are so strong, so rigid, like a bone, they even give attachment to muscles. Weight is being transmitted through this membrane. You call it a membrane, you call it a ligament, it's okay. There is no rocket science. You don't want to call it intraosseous membrane, you can call it intraosseous ligament, but remember, use those terminologies which are commonly acceptable. Let me give you an example. There was a time, 1,000 years back, when people learned it, common peroneal artery. Now, or the term was common peroneal nerve. Now that peroneal concept is gone. People agreed on, no, this is not good word. Let's replace it. Let's make it more easy, because this word is not really fitting in. Because the name changes is not me and you. There are experts. They collect evidence. They sit down together, and their job is to make changing. So now it is being called as common fibular nerve. Before it was called as common peroneal nerve. But if today you will be talking about common peroneal nerve, maybe someone start thinking, what are you talking, gentlemen? Because where I was trained, I was taught my book is only writing about common fibular. But so many books, they write common peroneal. So there's nothing bad in that. But we should adopt what is new. Okay, you have to choose anything of your life. I always give an example of a car, but let me put something. Okay, you have to buy an iPhone. So will you go and look for where is iPhone 3 in this era today? Even if you find it, they will say, oh, keep it in a museum. It's good for museum. So you will be going for 12, because it's 12 time. So accordingly, we keep changing. Now, what is the valgus and varus? Oh, it's very good. It's a term which is used in orthopedic practice. It's not a normal day-to-day term. So I'm sure, and these words are derived from Latin and Greek and all that. So I have a nice picture for you. There I can explain you better. It's my next slide. So is there a difference between saying a muscle abducts the thigh and adducts the femur? In my opinion, if I'm not wrong, I prefer to say which of the following muscles abduct thigh or femur at, what is missing here? At what? At, I have to highlight, at knee joint. Let's assume this is working. We know there is no abduction, adduction at the knee joint. At knee joint or at hip joint. So we have to be, if a statement is complete, if I say water, you will be, what water he is talking? If I say I need water, it automatically means this person is thirsty, I need water. But by saying water, maybe you are in a agony, you are in a distress, somebody, oh, he's probably thirsty, that's why. But not in a normal situation. So when we write, we should write the complete terms. I make million time mistakes. I do it. Now, this image shows very clearly your valgus and varus. First of all, let's read this. Valgus is a term used in orthopedics to describe a condition in which a segment of a joint or a bone is angled outwards. Outwards from where? From the midline. Look at in this image. Can you see in this image? This leg has been, this patient is lying supine, and this leg, the surgeon or the person who's examining the leg, he's pressing here and he's pulling at this place. So he's bringing, this is the midline. Midline goes from here. So away from the midline. So that is a valgus test. A valgus, say if someone's leg is lying outward away from the midline, we call it a valgus deformity. If it's a permanent. If I'm doing it, a valgus stress test. So this is a valgus stress test which has been explained here. And then what is the varus? Varus is opposite. Inward angulation. So if I'm holding, let's say if I'm holding from here, and then I'm pressing from outside to inside, so that might become a varus. So this is the concept of a valgus. Valgus is away from the midline. It's a kind of abduction. And varus is adduction. But in orthopedic clinics, these terms has been very frequently used. I know it's not every time you think of it, but it is. Now, so we have covered the general things, general questions, because I classified your questions. Guys, your questions were divided in two folders. One question where we have selected those where we need to talk. And there is another set of questions, the answer has been there. The answer has been written and that folder will be shared. Atif was helping me for that. So he created both of them and then you'll be finding it. Don't worry for that. Now, let's talk about femoral neck fracture. It's a very burning topic and I can still see people need a lot to learn. So many people have misconceptions. May I explain why people have these problems? The problems are connected what? Let me share with you. Now I can see 172 people are listening to us, listening to me. So now this class is about 400 plus people. So now the remaining 400, the remaining 200 or this plus minus, their thought is, oh, I work whole night. I will listen to the recordings if it's available because it will be available. And I'll do in my comfort time. So when in your comfort time, you open up this presentation and then, oh, time is, I have to cover physiology, I have to cover Dr. Rasul's concepts and Hamadan and this and that. So there is a lot, Oni has spoken a lot. What should I do? I don't have time to listen to the recording. Now, where is the PowerPoint? Oh, Atas, where is the PowerPoint? It's not there. Atas writing me Dr. PowerPoint, they are asking about PowerPoint. Oh, it's there. Fine. Now this person is start going himself on that PowerPoint where he don't have any, this is my assumption, maybe I'm wrong, don't have any previous knowledge. Now he start crying, what the hell is happening to me? So when I get the questions from you guys, I understand very clearly that this person is reading this concept first time, or like what quality of question it is. That says this is the first time this person is connected to these slides. So now it shows this person has reached to this level. So many people are asking, so many people are still confused. There's a natural tendency. Guys, asking question is a good thing. I always encourage. That's why no matter what time you ask me, most of the time I reply back. If I'm busy in something, let's say right now somebody is writing me a question. Obviously I'm engaged here. I will not be responding. I'll be responding when I'm done. Like today, when I'll be done? Somewhere around 4. So around 4 o'clock, I'll be done. So Weil is here. Yes, let's listen to Weil. Yes, Weil.
I want to post one lecture. You're in lecture?
Yeah, I'm in lecture.
Okay. Which lecture is that?
Basically, they have arranged through Hana's review stuff. That's this kind of lecture.
Oh, okay, fine.
This is a mall lecture, which is not like they cancelled, so they find this slot. So they asked me to revisit the whole thing. Okay.
So when are you going to finish? So I can use the volume. When are you going to finish?
12.
12?
Yeah. Because my one lecture is organized by, the support team. Yeah, it's from 11 to 12, and now they have added this mall, which was cancelled. So both of them going in one shot. No, it's okay. It's your job to ask. Okay, guys. So when I'm saying when I'll be done after 4. So then I had time to look in that who was asking what, because I have so many commitments in me. Anyway, cut short the story. Femoral fracture around the femoral neck, a very important topic, and you need to know everything about it. At least main conceptual anatomical things. So now this person is asking in extracapsular femur neck fracture. Extracapsular means beyond trochanteric crest and trochanteric line. You said that gluteus medius and minimus will make the limb go laterally rotated. But how is this possible? Those muscles are medial rotators, not lateral rotators. Excellent. I have a full description in my upcoming slide where I'll be talking about why the limb goes in lateral rotation after fracture, intracapsular fracture, or I can say it's a proximal femoral fracture, why it goes laterally and why it's become short. So that there it will be explained. Relax, it's coming up. Why does damage to only the blood supply of the head of the femur causes avascular necrosis? So question is, why does damage to only the blood supply of the head of the femur causes avascular necrosis? So I will split this question. Any part of my body, if you don't get any blood supply, that part will die. And we call this as avascular necrosis. It could be my digit, it could be my whole upper limb, it could be my whole leg. So if the main artery is being cut and I don't have any other resource available, let's say you put someone in a cave, you close the entrance and there is no other way, only some air can go in, there are some holes. What do you expect? This person will survive who's inside? This person will not survive because the supply line is being blocked, is being cut, and he will die because of starvation. So my femur neck, if it's fractured, because the arteries who are controlling my head, who are giving blood to my head, if they are damaged, I don't have any other alternate to supply to the head. That's why it undergoes avascular necrosis. But not after 1 hour, it takes time. Now the second part of the same question, why doesn't avascular necrosis occurs, for example, at the shaft of the femur? Yes, it can occur if I block all the arteries which are supplying shaft of the femur. So if any part of the body still getting blood supply, let me go back to your first part of the question. In children, in early age of life, if someone has a fracture of neck of the femur, a child will survive. He will not undergo avascular necrosis because a branch of obturated artery with the name of foveolar artery is still supplying blood to the head of the femur. So the head will not undergo avascular. So in a child, if I see an X-ray, if a child broke the neck of his femur, I will confirm on an X-ray and I'm not worried for avascular necrosis because I know there is someone who will take care of him. But in adults, in old age, there is no someone. Someone is gone. There was another question, very interesting question. I'm sure it will be coming up. If not, remind me, I have to tell you about that. So I hope you are clear now that that why doesn't avascular necrosis occurs for example, shaft of the femur when its blood supply is compromised. Gentlemen, if shaft of the femur don't get blood supply, then what happens? This will also go if you cut all the supplies. So now blood supply is compromised in extravascular, extracapsular fracture of the femur. So now I have some images which I'm sure it will be helping you. But I gave you a broad concept. If I cut the supplies, that structure will die. And if there is something remaining, that will be prevented from dying. Now, you are looking at an X-ray which is showing you the fracture of the neck of the femur. Can you see that? My proximal femur is now free rider. It can go in any direction. The muscle who are attached, they are still attached. We all know iliopsoas is here. My gluteus medius minimus are here. And then maximus also onto a certain part. So these all muscles are there. This has been detached. So now it is detached. So now these muscles will not behave normally. They were doing something different normally. But now under this situation, they will react differently because someone who was protecting, someone who was preventing, who was controlling them is no more there. Before it was in a fixed place. You cannot do little bit. Now it is free. If anything is free, if you are not protected. The examples which are in my mind are not good, so I don't want to give those. Let's say a child going to a beach with his parents. 99% chances the child is protected and safe and will not drown. No stray dog will bite him. But if a child goes alone without anybody, now all the evils will attack on him and any worse can happen. So when my bone is broken and it is getting out of its normal working style, so now anything can happen. So those who are maybe helping, now they are acting weird because they themselves don't know what is happening. Because this bone was fixed, now this bone is being detached. Look at it, same picture. Head is here, my proximal femur is free. Those muscles who are attached, they will pull it up. So my limb will be shortened. And then at that time, same time, this iliopsoas muscle, who pulls it up in a big way? Iliopsoas. And who makes this rotation? Again iliopsoas. The glutei and other people, they are supporting. But the prime job is iliopsoas. If someone asks you, limb shortening, lateral rotation, due to fracture neck of the femur, your answer should be iliopsoas, period. Don't look at anything else. I always talk about there are prime structures and there are associated structures. So first we should talk about what is prime. Are we good? So you should be clear about these things. Why is not? Because the support is gone. It's not normal. So there is no one who keeps him where it should be. Unprotected. You are within your country, you are more protected. You are out of going to another part of the world, you are not that protected the way you were. Now, a very commonly asked question and where people are confused all the time happens. These are not simple concepts. These are complicated subjects. This is a pattern of blood supply. Broadly speaking, these cruciate, trochanteric anastomosis, they meant to supply the head of the femur. Now if somebody asks you, who's the main artery? Now situation goes different. Because so many people are there. Okay, let me give you an example. You are living in a joint family system. And your uncles, Your mom, your dad, everybody is working, everybody is bringing food and money to the home. But there is someone who is the main bread earner for his family. And if dad is there, he must be the main bread earner. If mom is the only one, she must be the main bread earner. Other uncles and aunts, they are supporting. The grands, they are supporting. But the main bread earner will be different. So, if you've been asked, what is the main artery? Who supplies? Who's responsible? You know, you use a word in Arabic, min masul. So, who's responsible? Then answer should be medial, circumflex, femoral artery. So you should be able to tailor what is the question and what has been asked. Now, going further down, this image shows me what? Fracture, neck. You can see that fracture neck is gone. All those who are supplying to the head, they are gone. There is no, a bridge is broken, which was connecting the things. And then the one which you can see coming from inside, that is no more working. So now this is an isolated bone, have no supplies. What will happen to him? Will he survive? Then it will go under avascular necrosis. Now, situation 2. Fracture is across these are my trochanterids, greater and lesser, that's their names, because one is big and one is small. If my fracture line passes from trochanter to trochanter, thank you, IT fracture. So now, this blood supply is there, and it has its blood supply. So there is no issue of avascular necrosis. Are we good? I don't think there should be any ambiguity. This is about, no. What is the difference between artery to the head of the femur and foveolar artery? I think I've talked about it. Artery to the head of the femur and foveolar artery, they are the same. So if I say head artery to the head of the femur, so many names can be put in that. But foveolar artery is a specific branch which is coming from obturator artery. An artery to the head of the femur, foveolar artery is an artery to the head of the femur. So many branches which come from this trochanteric anastomosis, they are going to the head of the femur. Make sense? So that's the difference. So all whosoever is going to supply the head of the femur, they are called as artery to the head of the femur. And foveolar artery is the only artery which is a branch from obturator, runs in the foveolar ligament and goes to the pit on the head of the femur. That's the foveolar artery. Okay. What is the artery that mainly supplies the head of the femur? It differs. If I'm treating an early age of life, someone 3-4 year old, the main artery here is obturator artery. But now, if someone who's an old age adult, blah, 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 medial circumflex femoral. So guys, the target is moving, is shifting. You should be thinking, you should be smart enough that what is happening. Okay, let me give you an example. Fever, everybody knows. And we all know when someone has a fever, give him Panadol. It'll be okay, it'll be fine. But is fever a disease? No, it's not a disease. It's a symptom. There are more than 150 causes of having fever. Fever is a sign, is a warning sign, which tells the body something is going wrong. Get ready. So, and every fever has its own style. Fine, Panadol will work. But alone Panadol will not work in all the situations. You have to look for who's causing this fever. Is this due to a sepsis? Is this due to the throat problems? Is this due to the eye problem? Is it due to the ear problem? Is it due to blah, 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 blah. So many diseases. So we have to be specific. Now, what are the muscles that are responsible for shortening of the femur, and what are the muscles that are responsible for lateral rotation of the femur when there is a fracture of the femur. Yes, I like it. So now I have to read it for you. In rotation of the femoral head, what happens? Femur, let me take this root away because it's obstructing your view. It's not hiding. Yeah. So what is happening? Under normal, in normal condition, rotation of the femoral head, when we rotate the femur at the femoral head, it rotates where? In the acetabulum. About a vertical axis that passes through the center of the femoral head. So vertical axis passing like that. So now what happens next? So now I'm talking about normal condition. Femur is not fractured yet. So who are the medial rotators? Anterior fibers of gluteus medius and minimus. Gluteus medius and minimus we talk about, they are abductors. Of which joint? We talk about it when we were talking about Tendelberg sign. So medial rotation is produced by the anterior fibers of gluteus medius and minimus. And who assist them? Tensor fascia lata. So they are the people who are responsible for bringing, I'm talking about normal condition. There are so many conditions, it changes. So when you're talking, you should talk with a context. Now, who restrict this medial rotation? Tension of the lateral rotators and ischiofemoral ligament. They are controlling it. It should not go as much. So the opposite part, I remember somebody gave you an example of tug of the war. People are pulling a rope from one side and another group of people are pulling the rope from other side. The team who's strong, they win. So I'm bringing medial rotation. So lateral rotators are acting. So they are controlling. It should not go like, you close a door. If there is a door closer is placed, the door goes slowly. But if it's not there, it goes, strikes. So anybody can damage his finger. If a child is there standing and the door comes in a speed, it's gone, disaster. So there is a control, slow release. So my medial rotator and lateral rotator, they are agonizing each other. They are against each other. And they are, by this action, they are controlling. There is a controlled movement. It's not a sudden movement. And who else is helping here? Ischiofemoral ligament is also helping in restricting medial rotation. Guys, these things are of concept. Now, I have a bunch of muscles called piriformis, obturator internus, superior inferior gemellus, quadratus femoris, obturator internus, externus, sorry. They are what? They bring the lateral rotation at my hip joint. And they are assisted by gluteus maximus and sartorius. So this is how. Now gluteus maximus is a huge muscle. Part of it is going to my iliotibial tract. Some part is doing this way, some part is doing that way. If you really want to do, you need to spend big time on understanding all the action. That's why we are not targeting you that you should come up with all the detailed actions. You should talk about main, big, specific action of a muscle. But if we go in details, this is just the beginning. We have biomechanics, whole kinesiology is inside. What happened, what changes, what pressure, what is this, what is that. That's not your job. Now, so lateral rotation, who restrict it? Tension of the medial rotators, obviously they are opposite, iliofemoral ligament. And there's the range given. If you don't know it, it's better. Now, situation reverse. Neck of the femur is fractured. Now what happens? The shaft is free to rotate about its own axis. Now, as I've shown in the previous X-ray, now shaft is free. Nobody is connecting it. It's a free rider. And psoas and iliacus muscle produce the lateral rotation. And also, when there's a contraction, they pull it up. So my foot will go laterally open. So the answer is limb shortening and lateral rotation. One prime person is iliopsoas. And that is the characteristics of fracture femoral neck. If I see someone, oh, I like that question. Somebody asked me, why is always said an old lady slipped in the toilet and she broke her right neck of the femur. Why right? Why not left? Excuse me. I don't know what was the coincidence. It's equally possible for both right and left. There is no specific reason for that why right. Left can be there. But thank you very much. Next time when I'll write this question, I will make sure that I will write left. So you should not be you or someone else who will be observing this. I like it, you're observing very closely. So we'll put left as an option, so it will help you. You know why? When we are planning, when we are preparing a case, we know the consequences, but now we have to see what X-ray I have, and when I have to bring an X-ray, oh, this X-ray is for very basic level students. So this X-ray should be very clear, straightforward, dot on the point, no ambiguity. But if you are in an advanced level, you'll see versatile type of X-rays. So when we are planning something for you, for your teaching learning, for your assessments, we try to go for the simplified versions. And trust me, it takes time. A lot of time goes for just selecting the resource material. I have seen people making a case and putting the values of a child and talking about an 70-year-old person. I have so many such examples, but let's zip off. Okay, so I hope you are good with this. Now you should be, I'm sure everybody should be clear. Why there is limb shortening? Limb shortening, my iliopsoas. Now muscle is free. Nobody is opposing him. Contracts. But before, this femur was engaged here. So there was limitation. It wasn't go up. Now it's not attached here. So when my iliopsoas contract, it will go up. So my limb will become short, and then it will rotate it. Because now it's free. It's not connected. It is out of its place. Okay. So now, iliofemoral is by far strongest and resist hyperextension, strain on the hip. Somebody was asking me, I lost the question, but I thought it's worth mentioning. Iliofemoral is the strongest ligament out of these three, and it resists hyperextension at the hip joint. So regarding the retinacular artery, I think I have answered this question. It's about the blood supply, circumflex. We talk about that. Guys, can I say one word? So many questions were asked earlier and they were answered earlier. This is one of the evidence. And this topic was discussed in Structure of the Week session 3. And this, I just brought this slide from there. And that shows you people are least bothered what resources you have. Oh, I have all the recordings. What the hell it is? It will not help you. Having it will not help you. Using it will help you. So that shows when this question emerged, they were explained early. This is an evidence. This is an evidence. I have shown in this room in 3rd Structure of the Week lab session. These slides are from there. So please, don't think this recording is nuisance. If you think it's wasting your time, sorry gentlemen, you need to change your style. Because we at Al Faisal, we don't believe in providing students a cheat sheet. These are the 30 questions. Go through them, 10 will be sitting in the final, everyone is happy. No, this happiness is not needed. Because tomorrow, when I'll go sick, when my family goes sick, who will treat them? If I'm not part of making good doctors, what will be the tomorrow for us? So, we want to see you as good, practically useful doctors for yourself, for your community, for your families, and for the rest of the world. Now, we talk about femoral neck. Now, Ankle joint. Guys, ankle joint, I did not, on purpose, I didn't go in details. But I saw a big number of people are engaged with that. I don't know what's the reason. But anyway, I just picked up the very basic type of concepts. So now this question was asked again, basic different injuries which are associated with that. Let me read this question. So the question says, for subtalar joint complex, do we need to know exactly the articulating surfaces of the anterior and posterior articulation? May I know? You have done the hand. Are we bothered for who's articulating which hamate, pisiform, trochlearum, trapezium, articulating here and there, guys? If you have enough time, you can enjoy in these things. But simply you should know that these are the main bones who are contributing in making this joint. I'm saying again and again, details, sky is the limit. I can spend weeks on only for explaining ankle joint. But I stayed foot, you saw it. Why I skipped those slides in front of you? I don't want you to go in those. If I say don't do it, then people will think, no, why we were stopped. This is in our inheritance. When we are asked, don't get in that, no, we should look at that. But why is being asked not to do it? So when we do it, we burn our hands. Don't do it. So simply you need to know how are the things. And this slide, which is already in your inboxes, this explains all about the injuries which are must know. So now, so many questions, they are from these red boxes, which has already been mentioned to you. That shows very clearly to me that people have not bothered even to look into this. And let me give you an evidence. Now, this was the question. Do we need to know which exact articulation makes the ankle joint more stable in dorsiflexion than plantarflexion? Now, this box, which is shown up here, is taken not from any other resource. This box is here. And the answer is written here. That tells me very clearly the person who wanted to know about this, he don't want to read this and he want this to be explained again. So the answer is written here. And the broad concept, I have just made this baby puzzle thing for you. Talus, calcaneus, tibia and fibula. So you can see that they are making, this thing has a name. We call it mortis. And look at it. These are the bones from the side. This is the talus. It fits in. So once your foot is in dorsiflexion, it's in a complete contact. And once you are in a ballerina style, you're in a plantar flex foot, so then it's all unstable. And then this explanation has been given here. I need not to go read it again for you. I think you can read it yourself. But the answer to this question is already with you. But please open your resources. You'll get it. It's written there. Now, there were some mixed questions. I think we can. Okay, guys, I was going through your chat. There were some very interesting topics I found. Somebody was talking about the when we are replacing vein for an artery. So the person is asking that can they bear high blood pressure? Yes, there's no problem. How to recognize posterior anterior on an X-ray? I will talk about it. But the best what I like is this. Is the attendance mandatory for this lecture? And this should be asked by Muhammad Yusuf. And then people were saying no. And then Muhammad Yusuf was very happy, delighted. He write Alhamdulillah. I also like his word Alhamdulillah. Because I presume Muhammad Yusuf knows everything. Good for him. So Yusuf is asking tibial portion of. I'll be coming to that. Don't worry for that. When we look at the sciatic nerve in the thigh, we call it any branch coming from it. We call it tibial part of sciatic or common fibular part of sciatic. But once it reaches to the leg, then it's common fibular, deep fibular, superficial fibular, and tibial. Somebody is putting that. Can PCL, gentlemen, I'm coming to that. Sarah, you're asking. Sarah, I have a separate section on knee joint. I'll be answering there. I think we can start because time is going. Okay, guys. So, some questions which are miscellaneous from upper limb and lower limb. A very commonly asked question. Why? Let me push it up. Why most shoulder dislocation occur anteriorly while the lack of support is located inferiorly? Thank you very much for asking this good question. And it shows this person is really connected. We agree, we talk about. The weakest part in my shoulder joint is inferiorly. So what happens? No matter is anterior dislocation occurring or posterior dislocation occurring. First, it leaves the glenoid cavity. First, it goes inferiorly. Then, if my anterior forces are strong, it will come anteriorly. If my posterior forces are strong, it will go posteriorly. Now, let's look at it. Who are the forces which are pulling this one anteriorly? You can see this muscle which has been shown in this image. This muscle is my subscapularis. And we all know this is from posterior part. Like this is how the body is. And now here we have attachment of what? Pectoralis major. So two very strong muscles. And they are pulling it anteriorly. So the posteriorly pulling forces are not really that great. They are also working in certain situation. That's why, remember the rule, it get out. The exit point is 1. Head goes inferior. So if it depends on how person fall, how the impact of injury has occurred. If person fall in such a way, and then the strong forces are living anteriorly. The posterior forces are not that strong. So it's most commonly seen, and we use the term anterio-inferior dislocation. Or we write, if other way around, posterior-inferior dislocation. We took your answers right if people wrote anterior dislocation, if people wrote posterior dislocation, right? But it's less likely that it stays inferior. It goes inferior, then it comes anterior and it goes posterior. This will happen, and that's the mechanism. So this is a conceptual question, and I'm glad somebody bothered to ask this. Now, a very commonly asked question and a complex subject where people are struggling with that. Now look at it. This is the normal. Let me get some annotation thing here. Now, this is my clavicle, this is my scapulae, acromion process, coracoid process. Look at these ligaments. They are anchoring the clavicle with the acromion. And then we have ligament between the acromion and the lateral head of the clavicle, acromioclavicular ligament. Now what happens? Somebody, separated shoulder is a term which has been used. And what happened in that situation? Somebody falls on his shoulder. This is one of the mechanisms. As a result of that, now look at this place. And we use the term separated shoulder is an injury that usually occurs in rugby, football, ice hockey, and different games. The lesion is usually dislocation of. So first component of this is what? Dislocation of this joint. What is this joint? This is my acromioclavicular joint. So this joint, my clavicle usually goes like that, right? And this will sink down because it has gone up. Actually, it doesn't sink down, it stays where it is. But clavicle, once it's been dislocated, the forces which are binding them together, they are gone. So these forces are gone, so it is released upwards. And on the other hand, these anchors, they are also damaged. The first component is with or without disruption of the acromioclavicular joint. Second, ligaments, more severe injury. So we have grades 1 to 5. Involve fracture, dislocation of the joint, and 3 is the clavicle may also get fractured. Middle third. So now let's look at all what happens. So now injury, this person fell down, got injured here. Now look at the slide. First we talk about disruption of maybe the mild problem, not that severe, only disruption at acromioclavicular joint. Second phase, so this is the acromioclavicular joint disruption. Now, my ligaments which are connecting the clavicle inferiorly with the coracoid process. What were these ligaments? Conoid and trapezoid. And these ligaments are called coracoclavicular ligaments, and these ligaments have two parts, trapezoid and conoid. So these ligaments damaged, so now my clavicle is more free. It will rise more. You know, if you see these players, especially the rugby player and these, wrestlers, sometimes you see their shoulder, something is rising up. What is that? This rising up thing is the clavicle, its medial hand. And because those ligaments have been damaged on repeated traumas and fall and different occasions, so their clavicles, if you look at their shoulder, there is some extra thing which has been popping upwards. And now the third component, that we might find a damage between the ligament which connects my coracoid with the acromion. Thank you. So we call it fracture and dislocation, and there might be a chance of fracture of my acromion. There could be fracture of clavicle, so many things. So in this situation, what happens? So now the hand will go, my dislocation of the shoulder, I will lose this contour. This is because of the head of the humerus. But in this shoulder separation, the hand will go like that. It will go like that because the connectivity is being lost. It's not where it has to be connected. So this separation of shoulder is a good concept and you need to be good at it. Now you are asking about, okay, I will cover with that part. I will not talk here. How can the doctor evaluate the function of rhomboid muscle? Guys, for every muscle test, there are different mechanisms. So, but for rhomboids, you have to do very specific. I don't want to go in those details because if you try to do that on top of these muscles, we have more stronger muscles. Trapezius is there. So it's a very specific thing. Only you need to know what is their job. What is the difference between acromioclavicular joint, coracoclavicular joint? Which one of them is strongest joint? Guys, you are asking acromioclavicular joint. Acromioclavicular joint, you have seen it. It was the first one to go. This was the one which was connecting the acromion end and the lateral end of my clavicle bone. And coracoclavicular joint, it was between coracoid and clavicle. And it was not really a bony joint, it was through those two strong ligaments, coracoclavicular ligaments. So in my assumption, and that's true rather, coracoclavicular is stronger than acromioclavicular. And as you have seen in my previous slide, the first thing was if that was strong, then it was going last. The first thing which was going was acromioclavicular. And then and remember, it all depends how severe is the impact, the mechanism of injury. Everything depends on that. Now, when, for example, if flexors of the hand don't work, okay, flexor of the hand don't work. Then if you extend your hand, you would instead be hyperextending it, yes, because there is no one opposing my extension. So my extension, my normal extension will be super because nobody is pulling it downward. So I can make something like that. Or if vice versa, if my extensors are not there, my flexion will be something very weird, very unusual. You might have seen in some people who are suffering from neurodegenerative diseases. Their movement, their actions are very strange, very different. Now, when for example, if flexors of the hand don't work, then if you extend your hand, you would instead be hyper, I think the same thing. Once you ask for flexor, now you're asking for extensors. Are the movements of the digiti minimi done by flexor digitorum superficialis, flexor digitorum profundus, or by the hypothenar muscle? Guys, any muscle who act on a joint, act on a part of the body will bring its action, and each of them is responsible for different type of actions. Let me complete your list. The hypothenar muscles are opponens digiti minimi, flexor digiti minimi, and abductor digiti minimi. So the fine movements, the intrinsic movements, very precise movements concerned with my pinky, those will be controlled by hypothenar muscle. But the strong movements, flexor digitorum superficialis, its job is to what? Bring flexion at, what is this joint? Middle. And profundus at the distal joint. So this is the job of the profundus, this is the job of the superficialis. And then we have the role of the lumbricals, and then we have the role of those who are flexors of my wrist. So this is how each muscle is doing its job. It's not like my flexor digitorum profundus is doing everything. No, flexor digitorum profundus is only doing this work. This work. This is the job of flexor digitorum profundus. This is the job of flexor digitorum superficialis. This is the job of lumbricals. You always ask Tata hand, guys. I told you that is for those who are doing some senior residents. If you discuss with them, that's the place where you need to discuss. Tata hand is not for you. It came by mistake in my present, because when we prepare everything, but it's not necessary that everything you need to be good with. Now, action, somebody was asking somewhere, actions of my gluteus medius and minimus. Primarily, they have so many. I've mentioned to you their anterior fiber doing this, posterior fiber. Every muscle has so many types. But primarily, if you ask me what is their main job, they abduct the femur at the hip. So this is how you should write. If I write abduct the femur, where? So abduct the femur at the hip joint, stabilizes pelvis on stance side, and prevents it from drooping on opposite side. An unsupported swing side, and they rotate thigh medially. Now you know how they rotate medially. Their anterior fibers are helping in that. But really, you'll remember for all these muscles, this many actions. If you are good with abducts the femur at the hip, one. Second, plays a big role in sagging of my pelvis. Enough. You want to do more? If it's been asked, then it's okay. But, when we prepare to survive. We prepare to excel. First, prepare to survive. If you are good with that, how you know that you are good with that? Once you are able to write in your practice, your MCQs, once you are able to do 70% plus is going right without any problem. Don't see the answers first. Match your answers. Oh, I'm able to achieve 70%. Perfect. Now you are a survivor. After survival, now I'll go for competition. Now you're targeting A minus and A plus. So then you add on everything further. Then you need to know all nitty-gritties. But First, learn to survive. Then, learn to excel. And I'm sure you can do it because it reflects from the quality of questions. There are few people who I know every class has some people, those who are having other activities, and they think at the end they can cover it. Most of the time it doesn't work, sometimes it works. But a big majority in this class to whom I'm talking, they are, mashallah, excellent. And I'm very hopeful. I'm seeing through your process, your progress, you're doing very good. You're doing very good. Those who are good, they are extra super good. And those who are a little bit weak, I see them, they are changing. Because they are with the very strong students. Now they are learning, and I saw their quality. There is significant improvement, and inshallah, I'm very hopeful that you will be able to produce good results. Your class is capable of making good, so do it. Now, we talk about the general concepts. Now, let's go in that. What is left? Knee joint. So many questions, needs hours and hours, but unfortunately we don't have. So how we can go about? So what are the intracapsular and extracapsular ligaments? Guys, intracapsular, you can figure out yourself. Your cruciates. Remember, nothing is intrasynovial. Things are intracapsular and extracapsular. Extracapsular, your lateral and medial ligaments, oblique, popliteal, this and that, they all are out of the capsule. And those who are inside the capsule, you know them. They are your cruciates and many. So you can fill in this list. I don't think this question is a very big rocket science. Could you briefly explain the locking and unlocking mechanism? Yes, I will. I have. I did it. It's written in your presentation. It's been explained in my lecture. Probably people have not listened to that. I'll do it again. It's an important concept. So, first of all, let's look at the question. Doctor, could you briefly explain the locking and unlocking mechanism? So locking is tricky, unlocking is very easy. Popliteus contracts, it brings the rotation, and then you can unlock your knee is unlocked. So, but now what is important is how we lock it. So locking the knee joint, there's a big detail for that. Let me read it for you, those who don't want to read themselves. Extension is performed by quadriceps, we all know that, assisted by tensor fasciae latae. As the knee extends, now I told you when you go to the lab, just hold a femur and a tibia of the same person, and preferably not plastic, the real one. The shorter and more rounded lateral femoral condyle, that is shorter and more rounded. It completes its extension. This excursion is complete about 30 degrees short of full extension. Till you have not achieved full extension, it has almost completed. And lateral condyle then rotates forward around the taut ACL and allows the longer and more oval medial condyle to glide backwards into its own full extension. So it allows, because this articulation, the articulating surfaces should complete their excursion, should complete their journey. And this passive medial rotation of the femur is part of a locking. So you are basically gone in a hyperextended format, which secures the joint in 5 to 10 degree of hyperextension when both cruciate ligaments, the tibia and fibular collateral ligaments and the oblique popliteal ligaments are all taut. They become very tight. The femur rotates as desired, described when extension occurs with the foot on the ground. So this is the mechanism. Just read it, sit down with these real bones and just practice it. I don't see any rocket science here. Only you need to know. Now this is the question I love to answer this. I like this question. Someone is asking the unhappy triad as it results from lateral rotation. Why the fibular collateral ligament is not injured? Person is thinking. Look at it. This person, what are they playing first? American football, soccer, rugby. Now the defender, he has collided. The person was, his one leg is on the floor, other one because he is running. Abduction by my medius and minimus. And this one is fine, otherwise he could not have run. And now this defender, he struck to his knee laterally. So let's look at the events. He stuck where? Laterally. He stuck here. So now he stuck here. So as a result, this part moved outwards. And then a pressure start building here. Can you see that? A pressure start exerting here. And if this impact was extra more, I can see disruption. Right? So they damage here. And there is some degree of rotation started occurring. So this rotation in either ways. And resultant is this. Impact was laterally. Impact was laterally. And the damage is medially. Because some rotation is occurring. They are all tight. And now, we use the term unhappy triad. So what you see, who's been damaged? Your tibial collateral ligament, your medial meniscus, and your ACL. Why this is happening? Because impact, the forces were acting on this side. And why meniscus is gone? Because medial meniscus is blended, fused with my tibial collateral ligament. And why ACL standing? There is rotation, and because the impact was so severe, so there was some rotation to get the stability of the body, whole body weight. So we have these 3 C's. So let's look at this concept in detail. I'm using again my own slide. Even these slides were shown you in the presentation, but this slide, I'm sure, I spent time. So mechanism of 3 C's of unhappy triad of knee. So now, this is in connection to that person who was skiing. And there was someone who was asking me also, how this bursa is separating the lateral meniscus from the lateral fibular collateral ligament. So there's a tendon of the popliteus and there's a bursa here. So if somebody is passing between, it should be separated. Nobody is passing between, so it should not be separated. When somebody is passing between, there is a chance of wear and tear. So to minimize that wear and tear, we need to have a bursa. So now what are these forces? So these are the classical injuries of the knee joint. Guys, there are so many mechanisms of injuries and some of you are involved in so many detailed mechanisms. On purpose, I didn't reply to those emails because that's not needed for you. Clipping injuries and all those things, that's not needed. So the classical injuries of the knee are unhappy triad of the knee. And now force abduction and external rotation of a semi-flexed knee with the foot planted on the ground results in injury classically known as unhappy triad of the knee. The triad of structure injured includes what? ACL, MCL, and TCL. I hope everybody knows what is ACL, what is MCL, and what is TCL. So forces are here. Look at it. Lateral forces. So impact on the knee due to forward movement of the body. This guy was skiing. So these are the forces and this is the resistance which is coming. So injury of the ACL, tibial collateral, so they are called 3 C's. So force abduction. As a result of that, we have force abduction. And that will cause. And this is fixed, it's not moving. So stretch will increase on this ligament, and that is my TCL. tibial collateral ligament. Now, the force abduction puts a stretch on TCL because this abduction which is coming up is a force abduction. And as a result, what? Ligament is now, once it's stretched beyond its limit, it will be damaged. Now this ligament, TCL is connected to my MCL, meniscus. Which meniscus? Medial meniscus. So now TCL is gone, medial meniscus is also damaged. It will be pulled because they are fused with each other. So I'll sustain an injury, a bucket handle type of injury. Guys, there are so many classifications. If you don't know about this bucket handle, it's okay. But remember this, medial meniscus will be damaged. Reason, it is connected to the tibial collateral ligament, but fibular collateral ligament, and as you can see in the image, is not connected to the meniscus. And second thing is, this all now there is more rotation. So we talk about rotational injury in extended format. So more rotation is occurring because this ligament is gone. So it results in more rotation. So external rotation of the leg due to flexion of the foot on the ground. And then it will result what? It will result rotational injury, those ligaments who are present in the sagittal plane. And we all know when I'm standing, let's say I'm standing in front of you. At this time, my ACL will be under max stretch. And if I produce more rotation and a sudden rotation, so there will be more susceptibility of the damage of my ACL. PCL, I'm driving a car, I'm in a sitting posture, I have an impact, a dashboard injury, proximal tibia, not distal femur. So it will go backwards. The head of the tibia goes backwards, but PCL limits, and then if after certain more, it will damage. So PCL is gone. How we confirm it? By doing these draw tests. Guys, somebody was asking me how these draw tests were done. One minute. So I hope you are good. So now why we call it unhappy triad? This is unhappy triad. Triad means 3, not 4. Muthallas. 3. Who are these 3? My tibial collateral ligament, my medial meniscus, and my anterior cruciate ligament. They all damage. This is called unhappy triad. If they all damage, it's not necessary that they all should be damaged. It depends on how strong are the forces. If I go back in my previous slide, you were shown grade 1, grade 2, grade 3. When we achieve to grade 3, then we land up with unhappy triad. But there are people, after having impact, if impact is low, it's not necessary that you should damage your meniscus and ACL. You may land up with only damage to that TCL thing. So it depends on how it's upcoming. Now, how does the bursa, I think I talk about it. I read that PCL is often tiered because of contact injuries. Guys, I told you I'm not going in detailed mechanisms. So now this person is asking, what does contact injury mean? So, welcome to the club. First finish this, then we will talk. Let's not put people in this detail. Not needed for Saturday. Now, foot. I always say on my foot. So in foot, I didn't spend good time. Does the lateral and medial tarsal arteries branch from? Yeah, obviously you can. We talk about that. Go back to the recordings. Please talk more about the arterial anastomosis of the foot and related injuries to arteries in the foot and the ligaments. Guys, I'm avoiding details of the foot and you are asking me. So the arterial anastomosis we talk about, we have contribution from anterior and posterior tibial arteries, and they are making simply what you should know. Zubda. What you should know, anterior and posterior tibial arteries are contributing, they make arches, and they give digital branches. If you know this much, fine at the moment. Further, I don't recommend at this level. Do we need to know the difference between the common and proper? I think I answered for the hand, same goes for the foot. Do we need to know the exact digits supplied by either the superficial or deep branch of the medial plantar artery? No, it's not that detail required. Should we know the exact bones taking part in forming the medial longitudinal arch? Yes, we should be knowing that. And that's why I brought this picture for you. Guys, something which is really relevant, important, and must know at this level. You know, when we categorize your questions, we don't call them questions, we call them items. We see that, is it a must know? You know, when the report which you receive, it says must know, good to know. You remember something like that? So, the question was, do we need to know the bones? So, lateral arch, primarily speaking, bony contribution is very minimal. But we should know who is the main keystone. But the medial arch, you can see that, calcaneum. Then you have which cuneiform, which metatarsal. So if you know the name of these bones, you're fine. This is the transverse arch, which are named the bones which are participating. So this is how we can figure it out. Only you need to know this much detail, not. And then what are the other resources? You know, I mentioned to you what are the ligaments, what are the other structures. Only names are good and their practical implication. Could you please explain the mechanism of foot drop? So foot drop regarding the muscles. So guys, foot drop, basically what is foot drop? I'm unable to bring dorsiflexion. That is foot drop. So who control the dorsiflexion? The muscle who lives in the anterior compartment. And what is the nerve of those muscles? Is the deep fibular nerve, branch of my common fibular nerve. So either if deep fibular nerve damages or even common fibular nerve damages, I will lost, if common fibular damages, I will lost two of the things. Eversion and dorsiflexion, both will be gone. So if my deep fibular nerve is gone, I cannot bring dorsiflexion. Or my muscles, what muscles are there? Tibialis anterior, extensor hallucis longus, extensor digitorum longus. So if these muscles are not functioning, their nerve is not functioning, the person will develop a foot drop. And then when, for example, if flexors of the hand don't work, then if you extend your, I don't know what this much I have received. If flexors of hand don't work, then if you extend, obviously when you extend, you cannot make a uniform fist. Probably this might be the remaining part of, this is how I received. What is the difference between the medial and intermediate dorsal cutaneous nerves and the lateral cutaneous nerve of the foot? Guys, my lecture is almost ready and I'll be posting it to you. That will be talking about all the nerves. So there you'll find it. That's not a rocket science. Somebody was asking me posterior cutaneous nerve of the thigh coming from where, that will be covered there. So now, we are done with this much part. Now, a very interesting part. So many people were asking questions. How the questions will be? They will be like an MCQ, they will be like SCQ or whatnot, or fill in the blanks. Guys, for this OSP, the original plan was we wanted to do on campus physical OSP. But then we saw that the COVID situation and people are not adhering to the guidelines and so many. Then we decided not to go for any major risk. Because there is movement. When you're coming for your final exam, you're sitting on a place, you're not moving a lot. And then, but once you're moving, and it's a big, moving and controlling 400 plus people, it's not a joke. And then keeping the privacy and secrecy of your questions. And then maintaining. We were able to do it in past, but that time there was no COVID. Thanks God, yesterday Pfizer has announced some good news. Let's hope it goes through. Now, OSPI. The format of the questions you will be having, I wrote to someone, I think, that we will be following the same plan as you have seen that during our normal lab session. Some questions will be having some open-ended answers, but these answers should be, questions are designed in such a way that you should finish the whole task. We calculate everything. You can read the vignette. Vignette usually are very small, which are used. Vignette should be small. Uh, Images should not be many. So because you have to read, you have to connect, and then you have to think for an answer, and then you have to type an answer. So either you have to type an answer. So this will be kind of an open-ended type of thing, but this answer will be very short. Second variant you will be find, we will give you some structure, you will be provided a situation. Now you have to drop the pins, hotspot. When somebody asks you share your location from your mobile, you drop the pin on a map. The same concept is there. Remember the bottom part, the pin part of the, when you're dropping a pin, it should be lying. And I think if I'll put that thing, we will circle that part. If it's a broad area, we'll circle that. We'll give you a little circle. Select which one of the marked muscle is responsible for this activity. So you have to drop the pin within that circle. If it's out of that circle, automatically ExamSoft will not take your answer. So, and OSPI questions will have some histology and gross related, some questions on cadaver, X-rays, models. So almost all the modalities will be used, and we will try not to bring any surprise to you. It will be within, guys, all the exams should be within the objectives. I said in the beginning, and we always try to do that. That's why preparing an exam is not a joke. There are certain people who prepare it. There are a group of people who sit down and argue on those. Then there are a group of people who look for that, are they difficult, easy, or intermediate? And then there are people who look for other things. And even then there are some plus minus. No one is perfect. Mistakes, we try to do minimize, but sometimes it's there. And then when you write your exam, then ExamSoft does an item analysis, and we know where and what is happening. So there are so many things. So I hope OSPI related, given a situation, and according to that situation, we will ask you. And we prefer that you should write something. And this is not a theory exam. This is a practical exam. So you'll be engaged in practicality. So you have to identify something. On the basis of our identification, you should correlate something. So you can, let's say, I'll put a picture of foot drop. Then I'll put a picture of leg, showing two pictures of leg, showing anterior posterior compartment of the leg. Which one of the muscle is it? And muscles are circled. So you have to drop your pin on the muscle group, that this is because of this or because of that. So something like that. Do we need to know angiogram? Yes. So if we taught this, then why we taught? You need to know, you need to identify. Basically, what are we expecting from you on an angiogram? We are expecting that you can say this is popliteal, this is anterior tibial, this is posterior tibial. What else? This is ulnar, this is radial, this is. So these kind of things, not really rocket science. Is there videos? I think we will see to it. I wrote in my email that we might use video, but it depends. With the frequency, some part will be asked more, some part will be asked less, but things will be asked and inquired. Be rest assured. And will not be asking other than what has been taught. I hope that clear up the things. And now is the time to say bye-bye. I really wish and pray for your success. I tried my best to communicate, to deliver from best of my knowledge, to reply you with all my efforts and energies, despite of difficulties and other things. But I did my, I think I did my level best, and I leave rest to Allah. He is the most merciful, and I wish and pray that all of you should reach to the best level of success, and you should be happy and prosperous and flourish. With this note, bye bye. Assalam.
Thank you, Doctor.
Welcome. Anything else?